Hello, and welcome to the Alabama Public Health Training Network. I'm Carolyn Miller with the Alabama Department of Public Health. Thank you for joining us today for our program, Newborn Hearing Loss, the Importance of Early Detection and Support to Parents and Families. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years for nurses and social workers, expiring on August the 31st, 2022. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. However, if you are a care coordinator working in the newborn hearing program, there is a post-test that you are required to complete. It is in your information on your handouts. For social workers, if you're watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenters today. First, we will have Leanna Rambo, newborn screening nurse educator with the Alabama Department of Public Health. That will be followed by 2 parents of children who are either hard of hearing or are deaf. First will be Mila Macias. She is a co-worker of ours at Public Health with a beautiful 3-4-month-old baby, Mila, that she will be talking about. When she's not taking care of Mila, she is working in oral health and family health services as the fluoridation coordinator. Then we will hear from Maria Katz, who has a son that she has raised who is deaf, and she will be telling us about her experience. She is co-founder of Alabama Hands and Voices in Birmingham, Alabama. Welcome to you all. I know you have a lot of important information to cover today, so let's go ahead and get started.
Thank you. Hi, I'm Leanna Rambo, nurse educator for the Alabama Newborn Screening Program with the Alabama Department of Public Health. Today we will be discussing the Alabama Early Hearing Detection and Intervention Program, also known as Eddy. Today's objectives are: describe the purpose of the Alabama Eddy program, describe the Joint Committee on Infant Hearing JCI 136 Guidelines, discuss the process for inpatient and outpatient hearing screens, identify the purpose of early intervention, or EI, and the role it plays with hearing loss. List 3 learning communities and 2 family-based organizations. Describe the role of the care coordinator in the Eddy program. So the Alabama Newborn Screening Program, we actually cover 3 different areas. So there's the blood spot specimen, or blood spot screen, the hearing screen, and the pulse ox screen. Testing every newborn for certain harmful or potentially fatal genetic, hormonal, or congenital disorders that aren't otherwise apparent at birth. So a lot of these babies look normal to the nurse, to the family, and they have no idea that anything's going on. Alabama currently screens for 31 of 35 recommended disorders. Screening is not intended to be diagnostic, and newborns with suspicious findings must undergo further testing and clinical evaluation. So as I stated, we have 31 primary disorders that we follow. The first one on here is sickle cell disease. There's 3 primary hemoglobin disorders, so it's actually sickle cell disease, sickle cell anemia, and beta thalassemia. Some of the other ones you may be familiar with are cystic fibrosis, congenital hypothyroidism, congenital adrenal hyperplasia, other metabolic disorders on here, amino acid disorders, fatty acid disorders, and organic acid disorders. The most recent one that we added to our panel is SCID, which is severe combined immunodeficiency. These are all collected on the blood spot specimen filter paper and then sent to the Bureau of Clinical Laboratories for analysis. Other disorders that are also screened for at a birthing facility are what we're talking about today, hearing loss, and critical congenital heart disease, or CCHD. So back to hearing. Among the newborn screening conditions, hearing loss is considered the most commonly occurring disorder, with 1 to 3 infants born with some degree of hearing loss. For us here in Alabama, that could mean as many as 170 infants could be born with hearing loss in 1 year. Babies begin to learn to communicate through hearing before they are even born. At 3 months old, babies will smile when spoken to. At 6 months old, they begin to babble and talk. When babies cannot hear, this process of development will be delayed and can affect cognitive development. For this reason, early identification and intervention is so important. Infants with hearing loss who receive intervention by 6 months of age have the best opportunity to develop speech, language, and social skills. So what is Eddy? Eddy refers to the Early Hearing Detection and Intervention Act that was enacted by Congress in the year 2000 to provide funding for early hearing and detection programs nationwide. The goal of Eddy is to maximize linguistic competence and literacy development for children who are deaf or hard of hearing. This can be accomplished by meeting the goals outlined in the 136 plan, which we'll talk about soon. Alabama's Listening is the Eddy program for the Alabama Department of Public Health, initiated in 2001. All babies born in Alabama will receive a hearing screen, and results are tracked to ensure early identification, treatment, and intervention of infants with hearing loss. One of the most important legislative actions has been the development of the Early Hearing Detection and Intervention Program. Congress first authorized the Eddy programs in 2000. The legislation and subsequent funding Congress provided have helped establish the statewide Eddy programs across the United States that are identifying children with hearing loss and directing them to early intervention services. In late 2001, the Alabama Department of Public Health established the Universal Newborn Hearing Screening Program with voluntary hearing screening. In 2008, a mandate for universal hearing screening was established to ensure that every infant received an initial hearing screen and that the results were reported to ADPH. The administrative code pertaining to the care and treatment of infants identified through the newborn screening program states, the healthcare provider shall report the results of any hearing tests performed on the newborns to the Alabama Department of Public Health and shall use such forms and follow such guidelines as shall be determined by the state health officer. Alabama's Eddy program is 100% grant funded. We have the Health Resources and Services Administration, or HRSA, and the Centers for Disease Control and Prevention, or CDC. We follow established guidelines and best practices such as the JCI 136 guidelines, also the American Speech Language Hearing Association, or ASHA, and we follow the type, degree, and configuration of hearing loss. So, what is the 136 plan that we keep talking about? We know that the quicker we identify a baby with hearing loss, the better the outcome will be. The 136 plan outlines the recommended timeframes to accomplish specific steps in the diagnosis and intervention for hearing loss. So the first one, a hearing screen should be completed by 1 month of age. That's the one in the 136. So this can mean up to 2 hearing screens at the birthing facility and an additional outpatient screen following discharge while the infant is still less than 1 month of age. Secondly, this is the 3, an infant who does not pass their hearing screen should receive a comprehensive audiological diagnostic evaluation by 3 months of age. This may require a series of appointments and a variety of tests to confirm their hearing status. Thirdly, an infant with confirmed hearing loss should be enrolled in an early intervention program by 6 months of age, so that's the 6. This provides the best opportunity for every child to reach his or her full potential. In 2019, the new JCI Guidelines were published. The new recommended goals are 1, 2, 3, if 136 goals have been met. Alabama has not met the 136 goal yet, so we're still working on that before we move to 1, 2, 3. So hearing screen. Every infant should receive a hearing screen prior to hospital discharge. Ideally, this is done prior to 1 month of age. There are exceptions to this. If an infant is in the neonatal intensive care unit or NICU, the hearing screen may be delayed. In those situations, the hearing screen should be done prior to hospital discharge. An infant should receive no more than 2 inpatient hearing screens. So we're talking about in the hospital. Sometimes if the baby refers, then the nurse will do a second screen. We have had issues where they do 5, 6, 7 screens, but the recommendation is no more than 2. Both ears should be tested each time. So again, if a baby passes in the left ear, refers in the right, the nurse may then, or the technician may then just test the right ear, but it's recommended that both ears be tested every time. An infant who does not pass the hospital hearing screen should be referred for another hearing screen before 1 month of age, and that would be with an audiologist. So we're kind of going to be repetitive and talk about the same things over and over again just to help us understand. The Alabama Eddy program, in our state, there is one hospital that does not do the, there's one hospital that does the OAE screen, which is the Oto Acoustic Emission Screen for the well babies, but all the other birthing facilities in our state does the AABR, which is the Automated Auditory Brainstem Response Screening. So when it says that we're 100% capable, that means all hospitals can do that screening. They have them there available for them. It is important to note that if an infant referred on the AABR screen, the rescreen should also be an AABR. Hospitals should upload the hearing results every day they screen a baby. Most of the hospitals upload results electronically. These results link directly to the newborn blood spot record that we talked about earlier, which reduces errors in reporting and increases the timeliness of follow-up testing and intervention. So it's really important. There are 2 hospitals that fax their hearing screen results to the newborn screening program. If you're the care coordinator in that area, you may want to know that. So it's D.W. McMillan Memorial Hospital and Bibb Medical Center. So they don't upload their results electronically right now. They just fax them to the newborn screening program. So, recent developments within the Eddy program. We have a hearing advisory work group, which is a multidisciplinary group convened to create a more efficient and cohesive Eddy system, and they meet quarterly. I should say we meet quarterly. We do not call ourselves a committee, as we are a group that works together and exclusively for hearing loss. Our goal is to encourage timely language acquisition. There's also 3 learning communities in Mobile, Birmingham, and Huntsville. The learning communities are limited in our state, and we're working to increase those family support groups. So if you know of one, please have them contact us, or you can let us know about them, and we'll contact them. We'll talk about family-based organizations now. So the Alabama Eddy program partners with 2 family-based organizations. One of these is Alabama Hands and Voices. Alabama Hands and Voices is a parent-led, parent-driven, nonprofit organization supporting families with children who are deaf and hard of hearing, regardless of communication choice. They embrace parent and professional collaboration to enable children to reach their full potential. The other family-based organization we partner with is the Alabama Institute for Deaf and Blind, or AIDB, Limitless Beginnings. This is a grant-funded program to support families of deaf and hard of hearing children between the ages of birth and 3 years old, identified through the newborn hearing screening. Families have found that connecting with a parent who has experience living and raising a child who is deaf or hard of hearing is beneficial. Parent mentors meet with families on a regular basis and share their stories with positive, unbiased, everyday life experiences. They can meet in homes, remotely, or by other means. Children's Rehabilitation Services. So this is another Alabama Eddy partner. We often call them CRS. CRS is a statewide organization of skilled professionals providing quality medical, rehabilitative, coordination, and educational support services for children with special health care needs and their families. Every county in Alabama is served through a network of 14 community-based offices. CRS is also providing family support services through parent consultants. So this network provides specialty clinic and other services by physicians, nurses, social workers, physical therapists, speech-language pathologists, audiologists, occupational therapists, registered dietitians, secretaries, and administrators. CRS collaborates with local school systems and families to address the complex issues associated with disabilities and special health care needs. They provide education, training, specialized services, and assistive technology and devices to enable children with disabilities and special health care needs to attend, benefit from, and remain in school. Through services such as counseling, specialized therapy, and assistive technology for children and families, as well as disability training for teachers and other school staff, CRS offers the support vital to classroom success. The National Center for Hearing Assessment and Management, or NCHAM, is a vital part of the Alabama Eddy program. They serve as the National Technical Resource Center for the implementation and improvement of comprehensive and effective Eddy systems. The goal is to ensure that infants and toddlers with hearing loss are identified as early as possible and provided with timely and appropriate audiological, educational, and medical intervention. NCHAM has numerous resources available on their website, including training modules that some people might find helpful. And finally, Early Hearing Detection and Intervention Pediatric Audiology links to services. A long name, or Eddy PALS for short. They provide information, resources, and services for children with hearing loss. They have a national web-based directory of facilities that offer pediatric audiology services to young children. So that might be helpful for care coordinators to find. So here's a recap of what we've done so far. Hospital recommendations, we're kind of going backwards. The initial newborn screen is done at 12 to 18 hours of age while the baby's still in the hospital. We already mentioned this, a maximum of 2 inpatient hearing screens. They do upload the hearing results every day that a hearing screen is done, or they should. They screen both ears at the same time each time, schedule outpatient testing prior to discharge when needed, and notify parents of the date, time, and place of appointment. The referral physician, this is a big issue with the blood spot screen. The referral physician needs to be listed on the blood spot form, and it should be the medical provider who will care for the infant after discharge. Parents who refuse hearing screens should be educated on the importance of infant hearing and sign the refusal form. So the next slide is the newborn screening refusal form. There are 3 places there. I know it's hard to see, but one of them is the option to refuse the hearing screen. A family may refuse the hearing screening at the birthing facility, or a family may refuse follow-up testing later on. If a care coordinator encounters this situation, he or she should notify the Eddy nurse coordinator. The Eddy nurse coordinator will discuss with the infant's primary care provider and ask them to get the refusal form signed after discussion with the family. So we don't want the care coordinators to feel responsible for this. It's just a matter of passing that information along to the Eddy coordinator. Health provider information. So now we're talking about what the baby's physician, nurse practitioner, their medical provider, what they need to do. At the infant's first visit, they should review the hearing results. If no hearing results are received, they should call the hospital where the baby was born. If no results are available from the hospital, or if the infant referred on the hospital screen, ordering a hearing screen, AABR, with an audiologist within the first month of the infant's life. That's what we recommend. They should then report results to the Alabama Newborn Hearing Screening Program, or the Eddy program. I will note, almost all the hospitals, like we said, do the AABR screening in the hospital. So the recommended method for follow-up testing would be the AABR up until 6 months of age. After 6 months, it is up to the audiologist. The care coordinator, there will be times when they'll need to make office staff aware of the JCI 136 guidelines, so they will make sure the babies get timely appointments. Okay, so the audiologist recommendations. Complete outpatient hearing screens by 1 month of age. So we had the hospital, and then we had the doctor, so now the baby's seeing an audiologist. So ideally they would have that rescreened by 1 month of age. Then they're going to schedule diagnostic testing when needed by 3 months of age. Refer the infant with hearing loss to EI or early intervention as soon as possible and by 6 months of age. Educate families regarding hearing loss diagnosis and the importance of early intervention when applicable. Report all screening and diagnostic results via fax using the form provided by the Alabama Eddy program. And that's the next slide, is the outpatient reporting forms. So these are forms that the audiologists use to report results to the Eddy program or the Alabama Newborn Hearing Program, and they just fax that in. So the next thing is the care coordinator. So we're going to talk about what your role is in all of this. So as you know, a care coordinator is assigned a case based off the infant's Medicaid status. If the infant does not have Medicaid, Angela Daniel will follow the case, and Carolyn will talk more about that later. So the care coordinator's role in supporting families, you may help with transportation, communication with the doctor or the provider, links to insurance programs, emotional support, resources for other issues identified, and home visits as needed. The care coordinator may follow up with the hospital to verify final hearing screen results. So sometimes we get a result and we're really not sure what it is. I saw one the other day that we couldn't tell if it was a refer, if it was a R for refer or a P for pass. They kind of changed the the drawing on there. So there may be times where that happens, or where the baby referred on the initial screen, but the repeat screen passed, but we never got the repeat screen. So there are times when you'll just need to call the hospital and verify, is this the final hearing screen result?
Can I say something here, Leanna?
Yes.
This is why in your protocol we always encourage you to call the hospital first before you go on with the case, because they may have passed and then you can close out the case. So this is a very good example of why you call the hospital or the physician's office first before you call the parent.
Very good. Good rule of thumb. I do the same thing in my other follow-up. So, like we said, most all hospitals have the AABR capability, and the outpatient AABR should follow an inpatient AABR. So we've already said that. So part of your job is to ensure appropriate testing was completed. For instance, if they had the AABR in the birthing facility and then they follow up with their provider and the provider just happened to have the OAE screen and said, oh, we did the hearing screen and they passed, so we're good. But if they had the AABR initially, then the repeat needs to be the AABR. Okay. The care coordinator should educate the physician and family providing needed assistance to ensure appropriate follow-up care is completed. So you're going to help us find out the diagnosis. Was it normal hearing? Was there hearing loss? If hearing loss is confirmed, what type and the severity of hearing loss. So any information you get, pass along to us. An infant with confirmed hearing loss should be referred to EI by 6 months of age. You should know that by now. We've said it. We've said it a few times. So, or sooner if a diagnosis is made. And y'all are going to hear from Summer soon. I know y'all got referred a lot earlier because you knew. So you don't want to wait till 6 months. If you can find out sooner and get them there sooner, then that's better for everybody. Educate the family on the EI referral and the benefits of enrollment. Some families may be reluctant, they may be in denial, so your job is to kind of help transition them. There is a book called Pathways to Families, and it's rather large. I'll show it to you in the next slide, but you can provide that if needed. Now, if they go to early intervention, they will provide this book at that time, so it's not needed. But if a family refuses EI services and they still need that book, you can contact Mary Ellen and she'll help them get a hold of the book. So you also provide all contact information to the Eddy program for DHR follow-up when an infant is placed in foster care. So I will show you the big book. This is why we don't mail it. It's very big.
We've called it the Sears Catalog because
Yes.
it's about that size.
It's really big, but it's so full of so much great information. I tried to hit on a few things, but yeah, it's not on a website. You have to have a paper copy. It's a great resource, but it's big, so that's the only issue we have with it.
We have that in the revised protocol, and we have the link to it so that they can provide that to them. So.
Very good. Okay, so I didn't know there's a link. That's even better. So this book was developed to assist professionals and parents as they make decisions related to appropriate services and supports. It includes an in-depth list of organizations and websites, which is why it's so big. So, like I said, call Mary Ellen if you need a copy, and then Carolyn said she has a link to it. So, in case you forgot, the JCI Guidelines, again, 1 outpatient hearing screen by 1 month of age, 3 diagnostic evaluation by 3 months of age, and 6 enrollment in EI by 6 months of age. And you're part of the care coordinator's job is to ensure that all of that takes place. And if you can do it even faster, 1, 2, 3, that's even better. Reporting results. So provide accurate and complete information. Give us everything you have. Ensure the birth name is included. Verify the date of birth is correct. provide the most up-to-date contact information for the family. Accurate and complete information helps to ensure timely and efficient identification and intervention. And of course, you'll follow the care coordinator's protocol that Carolyn will talk about. The birth name, the mother's name, and the date of birth as provided by the hospital are key pieces of information that we'll use to locate the infants in our system and match them up to that blood spot screen. So, risk factors for hearing loss. You may talk to a family about this and they might say, we had no idea. So here's a few risk factors, and sometimes they just there aren't any risk factors, it just happens. But a family history of permanent childhood hearing loss, a NICU stay of more than 5 days, NICU neonatal intensive care unit. So if they're there for more than 5 days, then that's a risk factor. Exposure to ototoxic medications or loop diuretics, exposure to certain infections such as cytomegalovirus or CMV, or meningitis, craniofacial anomalies, head trauma, or chemotherapy. A child with or without risk factors admitted to the neonatal intensive care unit for more than 5 days. So that might be their only risk factor is the NICU stay. That's still a risk factor. The Alabama Speech, Language, and Hearing Association. So we're going back to types of hearing loss. There's conductive hearing loss, sensorineural hearing loss, and then they could have a varying mixture of both of those. So these are the guidelines we follow at ADPH. They may be found on the ASHA website. Not all hearing loss is the same, and the treatment will depend on the type of hearing loss. Audiologists can help. Conductive hearing loss occurs when sound is not sent easily through the outer ear canal to the eardrum and the tiny bones of the middle ear. Conductive hearing loss makes sound softer and less easy to hear. This type of hearing loss can often be corrected medically or surgically. So you may have a mom, I know Mary Ellen gets these calls, and my baby's fine, they respond to sound, we dropped something, they heard it, but that doesn't necessarily, they may hear a sound, but it could be muffled, it could be softer, so it's important to understand that when you're talking to a family. Sensorineural hearing loss happens when there is damage to the inner ear cochlea or the nerve pathways from the inner ear to the brain. Most of the time, SNHL cannot be medically or surgically corrected. This is the most common type of permanent hearing loss. SNHL reduces the ability to hear faint sounds, even when speech is loud enough to hear, or may still be unclear. It may still be unclear or sound muffled, like we were saying. So the next slide is the degree of hearing loss. There's 7 classifications ranging from normal to profound, and you can see those right here. And you might have a range. You may hear this baby had slight to moderate, mild to moderate, so there may be some of both. The degree of hearing loss refers to the severity of the loss. This table shows one of the more commonly used classification systems. The numbers are representative of the patient's hearing loss in decibels. There's also the configuration of hearing loss. It defines the degree and pattern of hearing loss across different frequencies. The configuration or shape of the hearing loss refers to the degree and pattern of hearing loss across frequencies or tones, as illustrated in a graph called an audiogram, and I didn't include that. So we've talked about the hospital's role, we talked about the health care provider, we talked about the audiologist role and the care coordinator. So now we're going to the Alabama Eddy program role. So we gather and correlate data. We manage and coordinate with providers on those who refer the initial screen. We have a nurse coordinator who works directly with non-Medicaid and Medicaid care coordinators to obtain hearing results. Her name is Nancy. She couldn't be here today, but she's watching, and you'll get to know her as you're working these cases. So we educate like we are today. We educate on JCI 136. We refer all hearing loss infants to early intervention services. We also manage the website to provide families and providers with up-to-date information. The next slide is some handouts that we have. They're available on our website. There's a link right there, but if you go to the newborn screening website, you can find them easily. This one is two-sided, so one side says parent information, is that right, Mary Ellen? And the other side is health provider information. So it's just a quick, pretty graphic to kind of get all your information in one place. We talked about several websites today, so I have a slide right here with just the web addresses. So of all the things, I got this information straight from their website, so you can go and look at those in more detail if you would like. Contact information for the Alabama Newborn Screening Program. We have our 1-866 number if you want to contact Mary Ellen Wiggin directly. She's our Alabama Eddy coordinator and nurse supervisor. Her email address is on here. We're about to move to our Prattville location, so that's why I didn't include the numbers. They're changing. But if you call that main number, we can get you connected, or you can email us. The other name on here is Nancy Strong. She's our Alabama Eddy Surveillance Nurse Coordinator, so she specifically follows the referred cases, and you'll probably get to know her very well. She's really sweet.
And I was remiss in saying that Mary Ellen is with us today. Mary Ellen Wiggin is sitting out here and helping us answer questions that might be above our heads. And she is with us as well today. So thank you, Mary Ellen, for sitting in today.
That's it.
Okay, we are going to have a change of speakers, and because of that, we're going to take a 10-minute break, and then we will be coming back with Mila Macias to hear her story in just 10 minutes. Welcome back to our program, Newborn Hearing Loss, the Importance of Early Detection and Support to Parents and Families. A note about our previous presentation, Facebook went down just for a brief period, so we missed a little bit of Leanna's presentation. However, all of the program will be on our on-demand, so you can go back and watch that short piece that you missed. My understanding is it was very little. I'm delighted to reintroduce to you all Mila Macias. You're about to hear all about Mila, who is the daughter of Summer and Ramiro Macias, and I had the privilege of knowing both of her parents. So Summer, I would like for you to continue with your presentation and tell us all about Mila and your experience.
Yeah, thank you for having me. So I'm a first-time mom. Mila is our only child, and no one in our family history has hearing loss. We don't have any type of history of any anomalies, so when Mila was born, and she was born with microtia atresia, which we learned quickly means that there is no outer ear and there's no ear canal. So Mila actually had her ABR test done at Children's Hospital in Birmingham. We were told about less than 24 hours after she was born that she was going to be flown to Children's, and we of course wasted no time. We barely had time to pack a bag, and we rushed up there and stayed with her for about 3 weeks in the NICU. Mila was born with more than just hearing loss. When she was born, she actually had an arachnoid cyst behind her eye, which was so large that it caused her eye to protrude. And she was rushed to the NICU because she needed surgery. So we were 3 days old having brain surgery almost, in addition to having hearing loss. And knowing that, she was going to need all of these interventions down the road, and having no experience with any of this as new parents, it was just very daunting. And, you have to realize you don't have just the hearing loss coming at you. You have doctors from every single specialty coming at you with information. And I kind of wished from the beginning I had a notebook. I was, blessed to have a CRS and early intervention, on board with us very early on. They gave us a care notebook. They gave us all kinds of resources, places we could go. We joined Hands and Voices. So we just, in learning about Mila's diagnosis with microtia atresia, with her arachnoid cyst, she was born with hip dysplasia, so she actually not only had her eye surgery, but she was fitted for a Pavlik harness, which if you've ever changed a diaper with a baby with a Pavlik harness, good luck. It was an adventure, to say the least. And then she later had a feeding tube because we learned later on that she was aspirating her milk. So in saying all of this, myself going through some postpartum depression, obviously, with everything going on, you think about all, throughout my entire pregnancy, how I was healthy. I didn't have any issues. My doctor told me one time that if he was having a baby, he would want it to be this baby. That's how perfect my pregnancy was. Mila was born full term. So we didn't expect any of this to go down. We didn't expect any of this to happen. And we, our bags were packed for a 2-day stay at the hospital, and we ended up spending 3 weeks at Children's in the NICU. We just were so incredibly blessed to have the support that we had through not only early intervention, but Hands and Voices, through CRS, through our work families, through friends, just people that knew that we weren't only new parents, but knew that we were also dealing with a child who had special needs. And we didn't know where to turn. We didn't know what avenue we should go down next, but we knew that she was going to need a hearing aid. And my first thought as her mom was that she doesn't have ears. How the heck are we going to get a hearing aid? So then we learn about the Baha, which is a bone-anchored hearing aid. Mila wears a Baha now, which CRS was amazing with. We went to CRS and we qualified for purchase services, which means that CRS would cover the cost of Mila's hearing aids, or whatever cost that our insurance, because we have private insurance, whatever they wouldn't cover, CRS would cover. So Mila was fitted with her Baha, which we do have a video to show a little bit later, but before then or leading up to then, she was just thriving at home, and we checked her, we looked at her for all of these milestones. When you have a child that can't really hear, you'd look and you say, is she going to coo on time? Is she going to babble on time? Is she, can she hear me when I look, when I sing to her, when I talk to her? We learned pretty early on that she has some hearing, even though she does not have ear canals. She has a bone conductive hearing loss. So what she hears may be muffled, and we were told by the children's audiologist that we would down the road figure out what degree of hearing loss she has, because she was so young at the time. She was only 4 weeks old when we had her tested. And babies don't really turn to sound at that point. So we're gonna wait a little bit longer to see what degree of hearing loss she has. But with her Baha, she has been thriving, and she does, like I said, have bilateral microtia atresia. That's the technical term for it. And she is 1 in 25,000 babies is born with this. It's most common in males, but Mila is just rare. She is rare, but she's also thriving, and she's so strong. And I just look at her, and sometimes it's hard for me as her mom, because you want to protect your children, and you want to protect them from the world, because we know how cruel the world can be sometimes. And I just look at her and I just think she's overcome so much already. I feel like she's a stronger person than I am, and this is gonna I feel more and more every week that goes by, because they really do grow up really fast. You hear that before you have kids, and then you actually have one, and you're like, wow, like every week we're noticing a new milestone. She's discovered her hands recently, and her feet, she reaches and touches her feet, and she's been cooing, and which, to have a child with hearing loss, when they start to coo, it's like, oh my gosh, regular parents are probably like, that's so cute, but we are looking up like, thank you, that this is happening. And that's because of early intervention. That's because, we knew from the get-go that she had hearing loss. We did something about it, and now she's meeting her milestones. And that's really what it's all about, is to, give them the best quality of life that you can. And that's what I want for Mila. As hard as it was to even admit, that my child had any type, of deformity, in her ears, let alone that she would need to be aided for the rest of her life, just knowing all of that, at the end of the day, it's really about the quality of life that you can give them. And by getting her tested and fitted as soon as possible, I feel like we're doing that. We're doing our best. But we came home, and she had to recover from surgery. She had her Pavlik harness removed at 6 weeks old. She has been rolling to her side recently, so she's meeting a lot of the milestones. And through the support that we've received through CRS, we have been able to reach out to other parents, people that have been where we are, and let us know that it's okay. It's going to be okay. Your child is going to make it, and it's really not the end all be all that you think it is. I'll be honest, and she was born on May 10th, so it's really not been that long ago that I was just in the darkest place thinking, am I going to have to quit my job? Is she ever going to go to a normal school? Does she, what can I do? When I sing to her, she can't hear me. When she's upset, I can't soothe her. All of these things go through your head. And when I was pregnant with her, I would talk to her all the time. So you kind of go back in your mind and think, did she hear any of that? Anything I was saying to her when I was pregnant. But now with her Baja, it's amazing. It's like the darkness just went away. We don't worry anymore about whether or not she's going to be okay if I can talk to her, or can she get a normal job one day. We have learned that down the road she will need implant surgery, so we're going to look into getting her bone-anchored hearing aids. About 5 years old is the FDA approval age for that, so that's what age we'll look into for that. And also down the line for microtia children, there is the option to have reconstructive surgery on the ears, but they don't do that until about 8 years old, so that's something that we want her to be a part of that conversation with. That's going to be a life-changing thing. So definitely want her to be a part of that, and is that something she's going to want one day as a cosmetic thing? So we'll have to look into that too. It's like a whole new world for us. We went from thinking that we were going to have this typical pregnancy, this typical birth story where you come home, you bring your baby home after 2 days in the hospital, right? But that was not our story. And, not only that, but we couldn't relate our story to anyone else. No one else close to us had any idea what to say, or because they had never really been there, and we didn't know anybody who had been there. But through Hands and Voices, through CRS, Facebook groups, I would say any parent out there that has a child with any type of disorder, if you don't know where to turn, there's a Facebook group for you. Mila had a feeding tube, there's a Facebook group for that. Mila has a cyst, and there's a Facebook group for that. We did get her tested with genetics. Thank God there's no genetic anomalies there. There's no, she doesn't have any deletions, so, we don't have to worry down the line about, does this hearing loss come with any other things? Because a lot of times you have to wait until they're 2 and 3 years old to figure out, oh, there's something else going on too, in addition to that. Children's has a great genetics department that offered to do a genetic test on Mila for free as part of their research. So we took it and said, please, and came back without any other type of genetic things. So it is scary. I will say that, and it still is scary. We're navigating a world of a very expensive device on a soon-to-be toddler. This morning we were taking her to daycare and she put it in her mouth. So, and they're not cheap. So, it is scary, and she's, at the rate she's developing, everything so far is on track. And yesterday she had feeding clinics. CRS is so wonderful. They not only got her fitted for the Baja, but they also got her set up with nurses and social workers and people that could actually observe her feeding, who gave us the confidence to go ahead and schedule another swallow study because she wasn't aspirating, and this was just yesterday. We went in and there was like a panel of 5 different professionals with different backgrounds who said, your daughter is ready, she can do this, you have nothing to worry about, keep working with her. They called Children's for us, they got her scheduled for another swallow. They just really take care of you at CRS, and you don't feel like you're doing everything alone. Because a lot of times when you're in this situation, you can feel like, especially as the mom, I tend to do this, I have to do everything. If I'm not doing it, nobody else will. And sometimes, in addition to having, going to work, and I have, we have our own lives outside of work, and we have family that we take care of, and all these other things going on top of this other stuff, it can feel like a lot. And so having professionals around you that call you don't have to remember to call them. Like, they're going to call you and check up on you. It's just been a godsend. It's been wonderful, and I am excited because we do have Mila's hearing aid video that's been in rotation since she had her hearing aid fitting. She's about 8 weeks old in this video. Right now, she's like 8 weeks old and so little. When I look at it now, she's so little, but now she's almost 4 months old. So she's had her aid for about 2 months now and just hitting every milestone. So yeah, you guys want to see that?
Okay.
Mm-hmm.
There we go. Perfect. Now, of course, she's got it up against the car seat, so it is going to be feeding a little bit. Oh, she doesn't like that, yeah.
Can I hold her head up?
Here we go.
Let's get you out of here.
But that was a reaction,
That
so.
was. Look. Mila. Oh. What is it? What do you hear? Is she hearing me? Hey! Mila! Mila! Hey! Hey! Mila! Hey! Hey! Hey, Mila! Do you hear Mama? Mila, do you hear Mama? What is it? What's that? What is it?
And two, it's going to take her,
happening?
she may wear it like 2 hours today and be done, and that's okay. Just every day kind of increase the wear time.
She's not really sure what's going on.
Yeah, this is a whole new sound to her.
Look at her. She's like, oh my gosh.
And I would say kind of like the calm, like looking like what's going on is a very normal response. A lot of my newborns that get hearing aids just kind of still a little bit.
Hi, baby. What you hear? Mila. Mila Rose. Mila Rose. Hey, it's Mama. She is fascinated. Hey, pretty girl. Hey, pretty girl. It's Mama. Oh my goodness. Hello. Hi. Hi. Oh my goodness, she's just so overwhelmed. Hi.
Yes.
Is there some feedback?
Nope. I was just.
No?
You want to make sure too when you're putting it on, you want to get it right back here.
Okay. Okay. Hey. Mila, what's going on, baby girl? So, it's gonna get me again. But that's, yeah, that was Mila, 8 weeks old, and that was my first time really knowing that she could hear me. Because leading up to then, I didn't know. I didn't know what she could hear. You know, can she hear me sing to her? Can she hear me soothe her or read her a book? We set up her nursery with so many books, and I just was so hesitant to do anything until we got her fitted for her aid. And now it's like we go home and we have our Disney Plus and we have our toys and we play, and there's just so much confidence that we have now in her development because she is properly aided, and she's eventually going to get a second Baha because there's they have asked, CRS is asking for 2. Right now we're working with the 1, but she's bilateral, so we're asking for 2, and we want her to have every advantage, and they're really fighting for us to have 2 of them, sometimes with insurance, so we're waiting, but she can definitely hear with the 1 for now. Yeah, it's just like a complete weight has been lifted. And so we've got her hearing checked off, and we've got her Pavlik harness has been removed, and her arachnoid cyst had been taken care of. We have ophthalmology appointments once a year just to, check up on that. And she's just going to do great things, we feel. So it's just a 180 from where we were when she was first born, and that's just due to all the early intervention and everything that, doctors and nurses and great people like social workers just care so much and take the time to make sure as parents we're informed and we're able to make the best decision for our kids, and that's what we're doing with Mila. So.
Leanna stressed, and I'll be stressing in our protocol, the 136 guidelines. You got all of your services very quickly. I mean, she's only 4 months old now, and we're doing 136.
Yeah.
Can you imagine if you had not followed the 136 guidelines where you would be today?
I cannot, and to be honest, it would be very scary for me, I think, if we were at this point and she wasn't cooing yet, and she wasn't, aware of her surroundings, and the fact that we got everything so quickly. I feel like a large part of why we got things so quickly is because she had a physical deformity with her ears. So they didn't say, oh, let's wait and do this or let's wait and do that. It was, no, she's definitely got hearing loss. Let's do something about it. But I would encourage anybody, even if you have no history of hearing loss in your family, you could be the 1 in 25,000 like Mila was. And, I feel like the only reason she didn't have to wait for a lot of services that she got was because of her physical, deformity. And we were very quick to act too because of that. But I feel like if she had gotten the ABR test, even without her physical, needs, if she had gotten it quickly and they told us she has hearing loss, I would probably jumped anyway, just to get her aided. It is really hard. I know it's really hard for anyone to tell you something's wrong with your child when you expect perfection. I'm at the age where all of my friends are having kids. And I have never seen one of my friends go through what we've been through. And so you don't expect it. You don't expect to be rare. You expect everything to be just perfect. And, she's perfect to us.
Yes, she is.
So.
Yes, she is.
Yeah.
Thank you so much, Summer, for sharing your story and being a part of us and being part of, and thank you for letting us be your work family.
Yes.
And,
thank you.
And sharing with us, because I think it helps to hear from parents.
Yeah.
So thank you again.
Thanks.
speaking of parents, we have another one. Due to our virtual learning, we recorded the segment for Maria Katz last week through Zoom, and we are now going to hear from Maria, who I believe her son is 15 years old. I'm looking at Mary Ellen because she knows him well. And not only has she had the experience as a mother, she has done some significant things to help other parents, such as Summer, through Hands and Voices, and has been a wonderful asset to the newborn hearing community. So we will now hear from Maria.
Well, hello, everyone. Care coordinators with Alabama Department of Public Health. My name is Maria Katz, and I am a mom in Birmingham. I have 3 sons. Their ages 16, 15, and 11. And my 15-year-old Lawson is the one who's deaf. So that's what brings me here to you today. I've been working with Mary Ellen Wiggin in newborn hearing screening to try to get, parents involved with the early hearing detection and intervention efforts. I feel like we're making a huge amount of progress. And, this is another kind of link in the journey is sharing a parent perspective with you all who are such an important part of this process. So I want to thank Mary Ellen, of course, for all that she does for babies and families in the state, and also want to thank Carolyn for giving me this opportunity, and then the tech team for getting me here this morning. So back to Lawson, I think I'm going to be able to share some pictures that will be layered in with this. So hopefully you'll see a picture of him when he was first born in July of 2005 in Birmingham at Brookwood Hospital. And it was a full-term pregnancy, which was quite a relief because my first one had not been that easy. I'd had placenta previa with my first son in 2003 and had been on bed rest, and he had ended up being born over a month early. So that was kind of nerve-wracking. But with Lawson, we didn't have any of that. So that was great. I'd had a scheduled C-section with him for a Thursday. And on that Tuesday at my baby shower, I went into labor. So I knew that he was ready to be here. And he was very healthy. He, looked great. No risk factors, of any sort, and, no hearing loss in either family. So he passed the newborn hearing screening at Brookwood on about day 2, because I'd had a C-section. I was in there 4 days, and I believe that was the second day. I think that was the same day they took him to the nursery for circumcision. In any event, it just kind of seemed like a non-event. I didn't even know, I guess, to be worried about that. And I certainly didn't know that passing the hearing screen didn't necessarily mean that he could actually hear or that he would continue to hear. The hearing screen used at that time at Brookwood, which I think was pretty much used throughout the state, was the OAE, which tests the functioning of the cochlea. So it tests for an echo. If a sound is put in and it echoes back, then the tester knows that the cochlea in the inner ear is functioning. Well, as we now know with Lawson, his cochlea did function, but he has auditory neuropathy, which means that the sound does not transmit from the inner ear to the auditory nerve and ultimately the brain. So the only way to have known that at that stage was to have done the ABR or the ABBR, AABR. I think there are 2 different variations of that test, but anyhow, either of those would have shown that the sound was not actually making it to his brain. But we didn't know that at the time. So in July 2005, we took him home and kind of resumed our busy lives. I am a lawyer by training. I had my own law firm in Birmingham at that time. There was a lot going on in Washington, D.C. for me. I was traveling a lot for business. We were renovating our house. We had a 2-year-old or an almost 2-year-old. so life was busy. And, at times I just remember thinking, something's not quite right with this baby. But I just could not put my finger on it. And, now that the whole story has come out, a lot of people had those thoughts, but also couldn't quite put their finger on it. Or if they did, hesitated to say something, which is very strange. I've never really figured that out. But my dad, after we'd figured this all out, said, I kind of wondered about his hearing. And then one of our babysitters said, I kind of wondered about that because he loves my cell phone. He was always rooting around looking for my cell phone. And there were a couple of times where I had my cell phone under a cushion on the couch and it started ringing and he didn't react, which seemed strange because he was always looking for that cell phone. So, there were signs, but, we had no kind of frame of reference for this because I basically didn't know a deaf person and, had no reason to think that his hearing was not working. So, but then at times he just didn't seem engaged. So I would bring it up with the pediatrician and I'd say, sometimes this baby just doesn't really seem like he's engaging. I mean, do you think he has autism? I mean, that was all over the news. I mean, I was just really kind of scrambling for an answer and then Lawson would seem fine. And so, I would just let it go. And the pediatrician would just flip to the end of the chart and say, well, he passed his newborn hearing screening, so he hears. So, maybe it's something else, but he seems perfectly engaged to me. So we went on like that for a while. I mean, I remember this one time when Lawson got a little older because he was standing up. So he must have been at least, 11 months. I was having a very animated conversation with my sister on my cell phone, and I'm standing there and I'm talking, and all of a sudden I look at Lawson and he's put his fist up to his, his head, pretending like it's a phone, and he's going, but he wasn't making any sound. And I was like, okay. Kind of filed that away. So about that time, he turned a year old, and the recommendation at that point, and I think now it's 2 years, but at that point it was to turn the car seat forward facing at 12 months. Prior to that, he'd been rear facing. So we turned around his car seat. And then another day I'm driving and I'm talking to him and I'm looking in the rear view mirror and he's just looking out of the window, just not acknowledging that I'm talking with him. And I was like, golly, I don't think this baby hears very well. So took him back to the pediatrician. They blew me off again, flipped to the end of the chart, passed his newborn hearing screening. And we kind of take it from there. But, then we were really looking out for things. And so by the time his 15-month checkup rolled around, I was like, we're not going to get pushed off on this anymore. We're getting his hearing tested. So they scheduled us to go over to Children's to have his hearing tested. But, it was like in the future because Children's was booked. So we started really panicking at this point because he's 15 months old and we don't think he's hearing. And so we took him to our ENT, which is an old family friend, as it turns out, is a adult ENT primarily, although no one really kind of told us that there was a distinction there. And, at this point, we don't even really know that there's a difference in hearing tests. We kind of think a hearing test is a hearing test. So they repeated the OAE at the ENT's office and said, we think he can hear. Maybe he can't hear well, but we think he can hear. But there's some fluid in his ears and his eardrum looks a little bad. So, why don't we put in tubes? So they did that, which, as it turns out, was just a wasted surgery. I mean, I'm sure his ears didn't look great, but, I think the hope was if you get the tubes in, then he's going to hear, because we'd heard that story from a lot of parents. And so then we finally make it to Children's, and Lawson was about 16, 17 months, and they did the sedated ABR, and he cannot hear at all. I mean, the complete bottom of the audiogram. And, so every indication was that he had not heard since birth, for the audiogram to be that bad. So, at this point, it's a mad scramble because, he's so behind. He's never heard one word. He has no framework for language. So it was super stressful for my family. I just remember just staying up late, researching things online, making call after call after call during the day, just trying to figure out our next step. Again, the process was moving very slowly at Children's, and the holidays were upon us, and, all of this kind of stuff. So we ended up taking him to Texas Children's, where we could get in pretty quickly due to a connection there. And they were able to do the cochlear implant candidacy review kind of in a condensed period of time. And we ended up getting Lawson his first cochlear implant when he was 20 months at Texas Children's in Houston. Again, super stressful because we had to travel with him a lot, very expensive. I started looking for ways to wind down my law practice and get out of the law business because, I knew I had to help this baby catch up. So, hopefully you'll be able to see some of this in the slides. And I also have some videos, which I'm going to share with you, and hopefully those will show up too, where you can kind of see the process of teaching Lawson to use his new ability to hear with cochlear implants. It was very, very slow. We had really, a lot of hope, but no, complete confidence that he was going to be able to catch up in time. And in my mind, in time meant school. If he's not ready to start school at age 5 or so, what do we do? And, and here he is too, and he's never heard a word. So you can see from the progression of the videos that it was a process. And, luckily, we were able to get him there. And that was, I think in large part due to the fact that so many people were able to put their lives aside to focus on this one baby, myself included, shutting down my law practice, really kind of pawning my, older child off on his grandparents a lot. I hate to say it. And that was hard for him. But, and then Lawson, he was a little fighter. He really kind of stuck with me. He had to sit in that trip trap seat, just hour after hour doing therapy. And he would just pass out after that. He would just be like face down on the dining room table or, completely passed out in the car seat. And I've got a slide of that too, which I'll try to share. So Lawson today is 15. He's 1 year behind in school, but he has a summer birthday, and he's a boy. So that's really not that big of a deal. And he's a little on the short side. So I think that actually kind of has worked to his benefit. So I'm just so very thankful for everyone who got us here. He doesn't kind of think his hearing loss is a big deal at this point, but, he has the luxury of feeling that way because so many people worked to get him to the point where he, can just go about his life. But, my takeaways for you is that this could have easily gone in a different direction had there not been a lot of things working in our favor to get Lawson caught up. He would have been woefully behind, and he easily could have been one of those kids who showed up at age 5 in kindergarten, which is the time you have to take your kid somewhere, with zero language because he had never heard a thing until he got his cochlear implants activated at age 2. So, for you all, you are really the line of defense, between babies and that, potentially bad outcome, because there are so many people out there who just don't take hearing loss seriously. Pediatricians, they may see one case in their entire career. And, they've seen a lot more of babies where you put tubes in their ears and then they hear great or, things like that. So, they're really, by and large, not inclined to take this seriously. Extended families will kind of talk you out of it. Like kind of no one wants to believe that a baby is deaf. And how can you tell? Because babies don't talk, for a long time. And by the time they're not talking, it's really too late. So, you all are very, very important in this process of getting families the answers. And, I don't really know how you do that with a family who's not necessarily looking for the answer, but, anything that you can do to get them there is just going to help these children immensely. And then my other takeaway would be, ABR. I mean, I know that some hospitals don't use the ABR to the extent that we can get them using it. It's a big deal because apparently auditory neuropathy is there's a lot more of it out there than people realize. And the OAE is not going to pick up if a baby is deaf due to auditory neuropathy. And, certainly, I guess there are situations where a hospital just can't do anything but the OAE, but then certainly the follow-up from that, the follow-up from a failed ABR should never be an OAE. And, pediatricians a lot of times have the OAE in their offices, as do a lot of ENTs. And, I think a lot of families will not know that if their baby has a failed ABR, that they should repeat the ABR, that the OAE is not necessarily going to give them any valuable information. And then my last takeaway is thank you for, everything that you do for babies and families in Alabama. Hearing loss is really a kind of a silent, disability. It takes a while to show up, and you're the ones who can help it show up earlier. So thank you. And I look forward to meeting you all in person one of these days. Bye-bye.
Thank you, Maria, for sharing your story along with Summer. I think hearing from these two parents helps us understand the importance of our roles as newborn hearing screening staff, as well as care coordination, and how critical it is for us to not only work with the parents in education, but with providers as well, because identifying hearing loss and deafness is so critical to the development of a child. So thank you to both of you for sharing such personal stories, because they are important to hear. Our last portion of this training is going to be on newborn hearing care coordination protocol, which I will be going over. As you can see from your handouts, we have made revisions to our newborn hearing protocol. These revisions are highlighted in yellow. There are no major changes to our protocol. They are primarily clarifications and information on hearing tests to help you make decisions regarding care coordination services. The revised protocol includes some new attachments, which we will go into detail shortly. One of those is the Newborn Hearing Screening Reference Manual for Providers, Section 3, which pertains to the newborn hearing. Additionally, we have the document that we have always called Letter and Document Library, which of course has been in the document library, but we have now attached that as well to our protocol. Other changes in summary, and we will go into these in more detail, are we are stressing, I know this is a shock to you, the 136 guidelines that Leanna went over and I went over and we'll go over again. We will be going over in our new protocol the role of the new Family Health Services social worker dedicated to newborn hearing. Leanna mentioned that. We'll go into more detail. List of determinations for care coordinators upon receipt of referral. You'll be getting updated information if parents refuse testing in this new protocol, as well as resources for parents and families, and how to address a delayed newborn hearing test because of fluid in the ears. First in our changes is that manual I was talking about, the Newborn Screening Reference Manual for Providers. This is a really good resource for our care coordinators, and I would encourage you to print it out and keep it on your desk because it has a lot of great information in it. I love the flow chart, which is at the very beginning. It has a broad overview of everything that happens in newborn screening, and it's based on the Joint Committee on Infant Hearing. So if you have questions on what's going on, if you want to make sure that everybody's doing what they're supposed to be doing in the hospital, the providers, the audiologists, and so forth, look at that flow chart because it's really helpful. In addition to that, in this section is the guidelines for pediatric providers. As you heard from Maria earlier, not all of our pediatricians are well educated in newborn hearing loss, and this may help you as you talk to pediatricians about the importance of testing and getting the right test for those babies. There's also in this manual some additional information on children's rehab services as well as Eddy. We have a little bit of change in our definitions. All our definitions remain the same, but we've really strengthened them. We have distinguished between the OAE and the ABR, which you have listened to from Leanna as well as Maria today. We're emphasizing what age they should have each test in these definitions. The OAE is preferred for babies that are at least 6 months of age, whereas the ABR, or the automatic ABR, which is the AABR, is preferred for newborns up to 6 months of age. The reason why the OAE is for older is once you get to 6 months, the babies are a little more fidgety and it's easier to do the OAE test than the ABR. The ABR is also especially important for premature infants that are in the NICU for up to 5 days. In the definitions, we also have the child find phone number, which is included in the early intervention definition to make an early intervention referral for babies identified with hearing loss. Our biggest change in protocol is that we have additional staff on board. Diane Chandler will continue with all the responsibilities that she has in newborn hearing, which is reviewing records, making sure you're staying on task, helping you keep that 136 guidelines, and getting information from you as needed. So Diane will continue to do all of those things that she has been doing. But to enhance our program, we were able to hire Angela Daniel in Family Health Services as a full-time care coordinator specifically for newborn hearing. She is going to be providing care coordination services to all of our non-Medicaid hearing referrals. They may have private insurance or they may not have insurance at all. Previously, we've never really been able to do much with care coordination services for this population, so we're really excited about this, and we were able to use some grant funding through Newborn Hearing and the Eddy program to provide this service. In addition to that care coordination with the non-Medicaids, she will be verifying Medicaid on all referrals that come in. She'll be sending out the referrals through CCRS, which you probably already know because she's been doing this for a couple of months. If a home visit is required on these non-Medicaid newborn referrals, if Angela is providing care coordination services and suddenly she really needs a home visit to be made, well, it doesn't make sense for Angela to drive from here up to Huntsville to make a home visit. So at that point, we will be making a referral out to the districts to make that home visit for us, and then we can pick up the care coordination services after that. Now, those of you who've been working in newborn hearing realize we don't make those home visits very often. I think I did a study last year, and it was less than 5% of our referrals get home visits. Most of our information and most of the work we do with our parents can be done over the phone. But never say never. And if Angela is working a case that does need a home visit and it's quite a distance from where she is in Montgomery, we will make that referral out to you. If Angela is seeing a baby and suddenly they are awarded Medicaid, they're suddenly getting Medicaid benefits, then she will be referring that case out to you in the districts. And she will make those referrals just as she does now for newborn hearing referrals and send that to you through CCRS. And you know, oftentimes our babies are born without Medicaid and they do get it. And I'm sure some of you watching today have already had that happen. I know there has been some back and forth between patients that Angela's had referrals going to you and coming back. So in return, if you have a baby that has Medicaid and suddenly loses those Medicaid benefits, then you would be transferring that case to Angela. And it's very easy how you do that. All you have to do is email Angela, let her know this baby has lost Medicaid, and she will pick up the care coordination for that. It could go back and forth. I think there's been 1 or 2 cases where they had Medicaid, they lost it, and they had it back. So you may be going back and forth a little bit on that. So Angela will be there for those non-Medicaids and sending them out to you once they get on Medicaid. I mentioned earlier that there are some determinations for you to make when you get a referral, and this is new in our protocol. There are some questions to ask yourself when you receive a referral, and this will help you guide. This will help guide you in what steps to take as a care coordinator. Once you get a referral, you're going to want to ask yourself, was a subsequent rescreen already performed after the infant did not pass the initial hospital screening? I think I mentioned this to Leanna. Sometimes we don't get that second test results, and that's why we emphasize call the hospital first, see if they pass that test, and then we can go ahead and close out the case. What was the method of testing? Maria really stressed this. We don't recommend OAEs in hospitals on newborns, and we don't recommend follow-up with an OAE if they've had an ABR. So what method of testing was done? And that will help you determine what you need to do next. Was the infant admitted to the NICU greater than 5 days? That can make a significant impact on what type of test. And were both ears tested? Both ears need to be tested each time. I know time and time again, and I'm seeing nods from the newborn hearing staff, that they'll say, well, the right ear passed, so we just tested the left ear. No, you have to test both ears each time. So that would be a big red flag for you that you need to talk to someone and let them know that they need to be retested in both ears. Are there any risk factors known for delayed or late onset hearing loss? And if you can't remember what some of those risk factors are, you can go back through your slides, and Leanna went into some great detail on that. Another section that we have added to the protocol is about refusal of testing. Parents have a right to refuse testing for their children in newborn hearing. Sometimes that's hard for us to understand, but they do have a right to refuse. And sometimes that's based on religious tenets and practices. If that happens, notify the newborn screening program that these parents have refused so that the newborn hearing staff can refer them to the baby's doctor so that the baby's doctor can talk to them, educate them, and counsel them on the importance of newborn hearing screening so that they are making an informed decision as parents. Another new section that we have, a brief section in our revised protocol, is about delayed hearing tests. We have found that some of our providers are delaying hearing tests because children have fluid in the ears. The American Academy of Pediatrics has indicated that this should not delay a hearing diagnosis since it has the potential to further compromise hearing. That could make the hearing even worse. So they are encouraging doctors to go ahead and do that hearing test. If that is the case, if you find that pediatricians are delaying for that reason, notify again the newborn screening program if the test is delayed, and they will send out a letter. It's called the best practice letter to the baby's doctor. And it is found in Appendix C in your revised protocol. You will not be sending this letter out. We've put it in there so you can see what will go out. But the newborn screening program will send this letter out to the pediatricians, and it's the best practice letter. So that is another addition to our revised protocol. Those are all the additions of the revised protocol. So really not a lot changed. Mainly Angela Daniel coming on and providing services for non-Medicaid, and some additional information for you all that is in there. I do want to go over some reminders, some of which we've talked about a great deal on the program today, but I want to remind you of these and how it impacts what you do as a care coordinator for these babies and their parents. You need to know the difference between the types of newborn hearing screenings. We are seeing so much where people are doing the wrong test, the AABR and the OAE. Be proactive for the newborn. Maria said this beautifully in her talk, that people aren't doing the right test. And in fact, they wouldn't even test her child for a couple of years. We need to be educating our parents as well as the doctors on what tests need to be taken. Angela recently talked to a parent and explained to her that she needed to call her doctor and tell him the baby needed the ABR and not the OAE. So if the doctor's hearing from the parent as well as you, that makes a big difference. Advocacy is a very important part of what we do as social workers, and this is advocating for that child. So keep that in mind. Another thing is 136 is our goal, and this is so important. Summer has stressed this when she was talking earlier about she could not imagine Mila having to wait 6 months to get into CRS. Maria was a good example of a child who didn't hear anything for 2 years and how much that slowed him down. So that has to be our goal. In order to do that, we have to keep to strict timelines to verify appointments were kept and reschedule them quickly. When I'm reviewing records and when Diane's reviewing records, we see where parents didn't keep an appointment, but we're not checking for another 2, 3, 4 weeks. A month has already passed where they didn't keep an appointment for their test. And then it takes another month or two to find the parent and get them rescheduled. That's not going to let that child keep that 136, and that can impact their developmental progression. So remember that every time someone misses their schedule. With COVID, it's made it even more complicated because our CRS clinics were closed. When that happens, when we have someone that's closed, see what the alternative is. I saw recently where we had a child that actually had to wait 9 months to be retested because of clinics being closed. We need to look to see what else is open during that time, if at all possible, so that child can get tested. Otherwise, they're going to get behind. Don't close cases too soon. I get emails saying, can I close this case? I haven't been able to reach the mother for a month. She's not answering her phone, and the mail's coming back. Well, what else have you done to try to reach that mother? Have you looked to see if that baby has WIC appointments? Do they have an appointment with their physician? Don't be too quick to close a case unless you have exhausted every effort to try to locate that family and get that baby into treatment. We also see where people ask, hey, can I close this case? They've got an appointment with early intervention. Well, just because they have an appointment with early intervention or CRS doesn't quite mean that they'll keep that appointment. So we need to make sure that they get in for that appointment and that they are following their treatment before we close that case. So it's better to keep a case open longer than to close too soon. For medical providers who will not provide needed information, send them the standard letter about HIPAA. We are finding that hospitals, some early intervention clinics, and medical providers are not giving us information we need for follow-up. They're saying, I'm sorry, we can't give that information out unless you get a signed release from the parent to do so. Well, we're part of Eddy, and we are part of Alabama Department of Public Health, and we are supposed to get that information. So we have a letter for that. In this program, I think we have a letter for everything. But we do have a letter. It's the standard letter, HIPAA and newborn screening. And the date, the most recent one, is 11/9/2020. It's found in Document Library under Compliance and Ethics. It's very easy to find. Even I can find it in Document Library, and I have trouble finding things. So it's right there, and you may need to use it. If you're not sure if you should send it, please call us, and we'll let you know. I think that's my last slide. Yes, it is. Here's our contact information. You have Angela Daniel up there, Diane Chandler, and myself. You know that you can call and email us at any time with any questions that you have. We're here to help in any way we can. I'm looking at our email. I don't see any questions just yet. Do we have anyone who has called in by any chance? No one has called in. That means that we have done such a great job on this presentation that no one has questions. If you think of any questions that you may have after this presentation, do not hesitate to reach out to Leanna and Mary Ellen, their staff, as well as Angela, Diane, and myself, and we will be glad to help you in any way we can. Another reminder to the care coordinators who work at Newborn Hearing, this is not only for care coordinators who work out in the districts, but also central office staff. You must take the post-test that is listed in your handouts and resources in order to complete your training requirements for this program. This concludes our program for today. I want to thank Leanna, Summer, and Maria for being here, and thank you for watching.